Hello, everyone. It's great to see a full room. Hello, come in. We're actually starting exactly on time. Don't feel bad about walking in. Sorry, sun's bright. I'm going to move just a little bit. I'm very happy to welcome you to this Global Mental Health Snapshot, Global Mental Health at Duke, a snapshot, I think. And so our plan today is to give you some exposure, really at a glance, to 4 of our faculty members at DGHI that are doing global mental health research. I need the clicker. Sorry. Forgot that I had these. I will tell you a little bit about global mental health at Duke, but just very briefly, because our goal for today is to have you see some examples. Our hope is that it will be interactive. I'm really going to make them stop talking each after 8 minutes so that there'll be plenty of time for discussion afterwards. But hopefully we'll get through each of their presentations and then take questions, okay? Just briefly, I want to tell you that we are a research priority of DGHI, the Global Mental Health Focus and Group, and so this is a shot of our website, which we feel emphasizes our uniqueness, which is we do a lot of different things. And you'll see that in the 4 examples today in terms of populations, disorders, and the approach to research. I just want to show you, if you went to the website, you'd see these sections, and this is how you'd find the projects and the faculty members doing such work. And here's our lineup for today. So I don't want to take, and I'm Kathleen Sikkema, by the way, the director of the Global Mental Health Initiative. So I'm going to let each person, each woman, introduce themselves, and we'll go from there, okay?
Hello, everyone. I get to start. Very exciting. So my name is Franz. I'm a child psychiatrist at Duke. I work as a diagnostician on an FDA-regulated autism stem cell study at Duke with about half of my time. I wear lots of different hats. I supervise child psychiatry fellows at the Duke Child Mood and Anxiety Disorders Clinic. And in the area of global mental health, for the past few years, I've been working on evidence-based assessment and now evidence-based early autism intervention in low-resource settings, particularly in South Africa, which is my home country. So that should say, what work are you doing? So autism spectrum disorders, an individual with an autism spectrum disorder, has deficits in reciprocal social communication. So simply put, that means the simple back and forth of communication. In addition, they have restricted interests and repetitive behaviors. Based on CDC data, there has been a dramatic increase in the prevalence of autism over the past few decades in the United States. And this has made autism a global public health issue, which has caught the attention of the United Nations, the World Health Organization, and multiple governments and healthcare systems around the world. So if we're going to take a global look at autism spectrum disorders, we need a common diagnostic language. And by that I mean, if we're talking about autism in Durham, North Carolina, we need to be talking about the same thing in Beijing, China, and the same thing in Durban, South Africa. So I was a co-investigator on the KwaZulu-Natal autism study, which was funded by Autism Speaks as part of their Global Autism Public Health Initiative. And this study aimed to adapt, translate, and pilot an autism screening tool, the social communication questionnaire, and the autism diagnostic observation schedule, which is the gold standard observational diagnostic assessment for autism. We really chose to focus most of our attention on the semantic and not necessarily the linguistic equivalence in the adaptation process. So that means ensuring that the constructs stay constant between the original screening tools and diagnostic instrument and the adapted version. And I cannot underscore the importance of this more. And if there is going to be sort of a specialist child psychiatry or pediatric neurology focus on these types of projects, it really should be, in my opinion, in this area. So we're measuring the same thing. Simply put, very simply put, the screening and diagnostic tool worked well in the Zulu population that we worked with. It was able to identify most of the children with an autism spectrum disorder. And importantly, I came up against multiple challenges, which I think is important to mention in the global health world in general. And I think that these challenges pertain as much to assessment as they do to intervention. These challenges are around the cost of these tools. They're copyrighted. There is tremendous physical distance between people with the skills and people without the skills. Using the ADOS as an example, which is the Observational Diagnostic Assessment, only recently did Africa, 2 years ago, did Africa get its first ADOS trainer. So until that time, there was nobody on the African continent that could train people in this gold standard observational assessment. There are also challenges around supervision. As I said, I think that's as relevant to assessment as it is to intervention. But probably most importantly, I took away from my work on this project the importance of linking, sort of the ethical importance of linking intervention with assessment and allowing a sort of progression of these to run side by side. So once we identify kids, we have to be able to offer services to families that until this time have had very, very few options. So just a bit about my career path that has led me to global mental health. I entered this path through medicine. Very early on in my training in medical school, I was interested in global health, pediatric psychiatry, and to be honest with you, for many years I ignored my interest in psychiatry because I thought there was no way you could work cross-culturally in psychiatry. And I'm so happy to say that I've been proved wrong in that assumption time and time and time again through the work I've done in multiple low-resource settings in South Africa and Namibia. Through the clinical work I've had, 1 minute? Through my clinical experiences, I've also realized, I was also sort of put face to face with the tremendous treatment gap that exists for mental health, and particularly for child mental health disorders in low resource settings. And this led me to many, many years of training in the United States, which I won't go into. Suffice to say, I'm now faculty, so I'm on the other side, which is wonderful. And I view global mental health first and foremost as a clinician, first and foremost as a child psychiatrist. That's my orientation. And as a child psychiatrist who is specialized in early child mental health assessment and intervention. We know that psychiatric disorders begin early, that based on US data, 1 in 9 children have an impairing psychiatric disorder. Very few of these children have access to treatment. Importantly, even in Durham, North Carolina, very few of these children have access to treatment. There is a growing awareness that mental health is a significant contributor to the global burden of disease, and myself and other colleagues are of the belief that targeted early intervention can potentially decrease the global burden associated with psychiatric disorders if you start early, if you intervene early. So the current priority, so the current work I'm doing, I'm actually traveling to Cape Town next week, and we're starting to work on an adaptation of a parent or caregiver-mediated early autism intervention with colleagues at the University of Cape Town, as well as colleagues at the UC Davis Mind Institute. But broadly speaking, my area of interest is in early childhood mental health interventions, and thinking through challenges of adaptation, piloting, dissemination of various interventions for child mental health disorders, including things like parent-child interaction therapy, parent training, trauma-focused CBT, but starting in the area of autism and moving from there. So that's what I have to say.
Is this on? All right. I'm going to try to juggle a little bit. Can I stand here? Am I on? I think so. Oh. Mm-hmm. This is the difference between a Mac and a... I don't know what I pressed to do that, but I'll try not to do it again. All right, good afternoon. I'm Joanna Maselko, and I'm a faculty member here at DGHI and also in the Department of Psychiatry.
Right, I am a social and psychiatric epidemiologist, and the perspective to the approach that I take to my research is based in life course epidemiology. And most of the work that I do is really trying to understand the early origins of neuropsychiatric disorders, focusing on infancy, childhood, adolescence. And so, of course, it kind of lends itself really easily to looking at the family context. So especially at the early ages, the family context is really important, the mental health and otherwise health of parents, grandparents, and other family members. And so much of this is changing. So household structures are changing, people are sort of fewer nuclear families and so on. And so one of the things that we're really interested in is looking at how child development is affected by some of the factors that are changing within sort of this life course epidemiology perspective. All of the work that I do is in South Asia. So I have a working on project in Sri Lanka and India and in Pakistan. And I'm going to tell you a little bit about the Pakistan projects today, but I'm happy to answer questions about any of the other ones as well. Okay, so the project in Pakistan focuses on the treatment of maternal depression and looking at child outcomes. So we would expect that if you successfully treat maternal depression, that all sorts of things would improve for the child and that they would improve cognitively and socio-emotionally, develop better than children of moms who weren't treated for maternal depression. And so there was a really successful maternal depression trial a few years back, and the moms in the intervention arm breastfed more, played with their kids more. Their sort of their depression rates were much lower, and people were very optimistic that some positive impacts would come on the kids. And then 7 years later, we were able to go back, find the kids, and everything had washed out. So there's lots of questions in between there about what happened in those intervening years. So now we had, again, an opportunity to collaborate with a new trial, a new perinatal depression trial, and kind of embed ourselves and really focus on the child outcomes. So these pictures are just from this area to give you a sense of what it's like there. It's very rural, and there's some of our team down there. Okay, so the 3 hypotheses for this study is we wanted to evaluate the impact of the perinatal depression on sort of treatment versus the control arms. But not only that, feeling very optimistic about the impact of the intervention, we wanted to see whether this intervention children, they would start to converge in outcomes, in developmental outcomes, with children of moms who were not depressed. We wanted to look at parenting behaviors as mediators, and then we also really wanted to look at how all of these relationships change by social and demographic factors, everything from the family composition, socioeconomic status, presence of interpersonal violence, things like presence of grandmother and father, and so on. Okay, so this is just briefly the study design. It is a cluster level randomized trial. So the main program is this perinatal depression intervention, which is community based, and I can also talk a little bit more about that, although I'm not involved with the intervention itself. There's 20 intervention clusters, 20 control clusters. All women in these clusters get screened for pregnancy in their screened for depression in their 3rd trimester of pregnancy. And then they are enrolled in the trial. The intervention happens, they're followed for 6 months. What we wanted to do is say, well, we want to connect the dots. We're going to follow the children for 36 months and really do lots of assessments in the intermediate period to understand all of these processes that are happening. And then to be able to compare to the non-depressed, we then have to enroll non-depressed mothers as well into the trial. So these are women who are screened and aren't depressed. And we're going to follow all of these kids for 36 months. Now, this is actually, it ends up being a huge project, and this is something I want to mention, is that this is very, very collaborative work. This is a merging of multiple teams. It wouldn't be possible to do this within one research project. So on our team, between these multiple teams, there's clinicians, psychiatrists, psychologists, epidemiologists like myself, economists, and so on. So it's a very nice cross-disciplinary team. Everybody can bring their own approach to this. So we're just in the beginning phases. We got the grant in May, and now we are in the process of doing the prenatal recruitment and the prenatal screen and the interviews, and then the three-month postnatal interviews are soon, and so that's exciting because that's when we get to actually see the kids and see how things are going. And you can see all the different things we're thinking about measuring here. And I just wanted to point out the two in green. So what happened is this, one of the mediators that we were really interested in is parenting. And so things like responsiveness and stimulation, and there's several other ones. And the gold standard to assess something like that is to video record a maternal interaction with her infant or young child, like give them the activity, and then you can code it later. And we can't do that there, so we would expect about 25 to 50% refusal rate for women who, they say you can videotape their child, but not them, so that's problematic. So we had to come up with a different approach, and so what we're doing is developing an activity that can be coded live, and so we're developing it. We need to make sure we get it up to sufficient inter-rater reliability and so on. But this is, I bring this up because this happens in global health all the time, where sort of the things that exist don't really work, and so you have to start anew. The second place where this happened is we really wanted to know more about the grandmother involvement especially, and the father as well. And we weren't really satisfied with the measures that are available for for other people who spend time with a baby, especially in the context of these larger families. And so we're developing this, what's called kind of a day in the life narrative. So for the mom, she's going to describe everything that happened from the baby's perspective on a given day. And then we have a quantitative way to code everything, to code all the things that we want to do, all the things that we want to know about who the child spends time with. And through that, get a better sense of the grandmother's involvement, father's involvement, and maybe other people as well. So again, so these are sort of two things that we had to do all anew. So that's, I just wanted to mention that project, which is ongoing and very exciting, and sort of other projects and future directions. We have 2 other sites in Sri Lanka trying to understand cognitive health among the elderly, and also especially within the context of interacting with grandchildren and what that does. And then in South India and Kerala, looking at adolescent development and some of the risk factors there. And again, this is sort of lots of people coming together. It's one of the things I find most exciting in this field, is that you meet and work with people that are sort of from all perspectives, and we try to make it all work together. That's it.
Thank you. My name is Melissa Watt. I'm going to talk about my work on mental health and obstetric fistula in Tanzania. But wanted to just start, like the others, by saying a little bit about how I got here. I have training in my undergraduate from UNC and a master's from the University of Sussex in gender and development. It was a 1-year MA program. And then I was in South Africa for about 5 years working with the United Nations as a gender specialist and with a local NGO. And that's how I sort of came into the field of public health, which brought me back to UNC, to the School of Public Health, to do a PhD in health behavior and health education. And then I joined DGHI in 2008. And, mental health hasn't been part of my formal training, but it's something that, if I sort of reflect back on it, has been kind of a bit of an umbrella, or something that sort of has woven throughout my work, really because of the focus on overall well-being and thinking beyond physical health. So here at DGHI, I do work in Tanzania and in South Africa. In South Africa, my work is on HIV, substance use, pregnancy, trauma, and many different combinations of those. And I work primarily with Kathleen Sikkema, as well as Christina Mead, on projects in South Africa. In Tanzania, I did a Fulbright in Tanzania during my dissertation work on HIV and adherence, and now I'm going to talk about my work in obstetric fistula. But I think it, again, a lot of my work now really focuses on mental health, and it's done very collaboratively with others who bring different disciplines and training. And I would echo what Asha was saying about the importance of collaboration. So the work on obstetric fistula started about 5 or 6 years ago, and it really started with the idea of a graduate student. So if you're a graduate student here, don't think you can't bring your ideas forward and, in fact, influence the career trajectory of faculty members, because, in fact, you have that power. And we actually welcome it very warmly. So I just want to throw that out there. But Sarah Wilson was a PhD student in clinical psychology and had a real interest in obstetric fistula from some previous work that she was aware of, and is kind of understanding this issue in Tanzania. And came to us, to me and to Kathy, and said that she wanted to do this study in collaboration with someone who was at Duke at the time and doing work as a fistula surgeon in Tanzania. So all of us got together and we designed a study that then was funded by DGHI. And so we had an obstetrician gynecologist, clinical psychologist, public health, someone with gender background, and sort of it was very much a collaborative effort. So we did this very small observational study. I'll just say a little bit about obstetric fistula. It's an injury of childbirth. The typical story is that a woman is in obstructed labor, oftentimes for 3 or 4 days. The baby's head presses in the birth canal, and really what she needs is cesarean section, an emergency cesarean section, but it can be very difficult to get an emergency cesarean section, particularly in more rural areas. And so what happens is that flesh just necrodes and creates a hole, typically between the vagina and the bladder, but sometimes between the vagina and the rectum, and results in constant leakage of feces or urine. And so, and loss of the child. So typically, in almost all cases, the child is stillborn. So I really don't have to explain why this is a mental health issue, both in terms of the woman's own psychological well-being as well as the impact on relationships. So what we wanted to do is really just to quantify that and began to get some evidence on that, and not surprisingly found much higher rates of distress among women with fistula compared to women without fistula who were recruited from an outpatient gynecological clinic. So in August 2012, then, we took these findings to a community feedback forum that we put on that included stakeholders both in women's health, obstetric fistula, and general community health. And we presented these findings and began to facilitate a discussion about what was needed and where we should go next, in particular to move to an intervention. And that led to an application to the NIH. They had put out a call for funding, a program announcement, a PA, so there wasn't set-aside money, but it was talked about as a priority for research on obstetric fistula. And we applied for an R21, which is a small pilot grant, 2 years, typically used to develop and pilot test something that's novel. So in this case, an intervention. So in the first phase, we did intervention development. We started this in fall of 2013. We completed intervention development and are now doing a pilot test with 60 women. So through formative work, a lot of qualitative work, we designed an intervention curriculum that included individual counseling, 2 sessions prior to surgery, and 4 sessions post-surgery. And we were really able to identify sort of some target areas that we wanted to address. And there were a few lessons learned from the formative work and from putting together this curriculum. One is the importance of simplifying content. So we came in with a lot of psychotherapeutic approaches and theory, and what we realized is that those concepts really needed to be simplified. So for example, when we sort of began discussions about how do you reframe thoughts, the idea of thoughts and sort of being able to capture and identify thoughts was very abstract and very elusive. So what we ended up doing is having a list that we had heard repeatedly, both from our prior formative work as well as from this qualitative phase. And so instead of asking women to kind of to bring those thoughts into words. We sort of gave them a list of thoughts and asked them to identify those. Emphasis on social relationships and identity, that's important everywhere, but it's particularly important in a setting like Tanzania, where one's own identity and well-being really depends so strongly upon that of the larger community and people you're in contact with. The saliency of religious concepts, that was important for both Christian and Muslim populations, and in fact we found kind of the same ideas really resonated with both populations. There was just a bigger religious framework. And then tailoring to the clinical setting and seeing opportunities. So now we are in the middle of the pilot test, so it's a small randomized control trial, as you can see, with post and 3-month follow-up. I'm happy to say, since I sent these slides in on Thursday, we now have 35 women recruited and enrolled. Our follow-up rate has been excellent, about 80%, even though women are traveling oftentimes 8 to 12 hours to get back to the hospital. They just really really are looking for that recontact and affirmation from the providers. We see that the intervention is feasible and acceptable. But, you know, we ask a lot of questions of ourselves, so how much of it is the facilitator effect and how to distinguish content versus the warmth and the empathy that women are getting just through the contact of these sessions. And we haven't been able to look at outcomes yet, but as I sort of think about doing that, you know, we are going to have to show an impact above and beyond surgery, which is life-changing, as well as study participation. So I was there a few months ago and just talking to women about how much they enjoyed sitting down to do the surveys, to do the qualitative interviews, and how much they felt sort of accepted and affirmed through that process. And then it just raises a question for me, even if we don't see a significant impact statistically, can we still make the case for the importance of a psychosocial intervention? And how do we do that? And on the basis of what evidence do we do that? So this is just to end. This is Dr. Masenga, who's the fistula surgeon, and Pili Niendo, who is an intervention facilitator. And these are two of our women who have obstetric fistula at KCMC. And in the next steps, I'm working really closely with the evidence lab with Joy Noel Bumgardner to think about what are next steps and how can we begin to integrate this into fistula care programs. USAID is doing a lot of funding for fistula care programs. They really want to include a psychosocial approach, but thus far really don't have any tools. And so we're examining ways that we can use our lessons here to begin to integrate that more systematically.
Hi, my name is Kate Whetten, and we had a slide transition here. I lost a bunch of logos on this. So I want to say that, yes, I am in the Sanford School here, but also in DGHI, in the Center for Health Policy and Inequalities Research, and also, to emphasize what's been said here, work in collaboration with small NGOs in different parts of the world who are equally important to the work that we do. I come from a background of being a public health practitioner. I lived in Central Africa in what was Zaire, now the DRC, for a little over 4 years. I lived in China, I lived in Brazil, and came from a perspective of seeing tremendous need on the ground, tremendous need for health and well-being, and seeing as a common good kind of what we promote or want to have around the world, that families would kind of universally say, we want good health for our children, we want them to survive, and looking at well-being. So that became something that I was very passionate about, loved being a practitioner, loved being hands-on, but realized at some point that a strength that I had and could perhaps affect more people's lives would be coming back to the US and getting a graduate degree in public health. So I am a population health researcher. And like my colleagues, work in wonderful teams with statisticians and physicians, psychologists, psychiatrists, health behavior, health education folks, and all of that. I'm going to talk about, we do a lot of work with adults around HIV, substance abuse, mental health, Hep C, hepatitis C, things like that. Today I'm going to talk about children and the projects that we're doing in this area, and talk a little bit about kind of the life course of the way projects take off. And so this slide is just to show that we do different kinds of work. I don't know if there's a pointer on here. Also, maybe I won't mess with it because it'll something bad will happen. So we do the kind of work where we have cohort kind of longitudinal studies. So here we have a study called the Positive Outcomes for Orphans, funded by National Institutes of Health. It's in different countries around the world. And it is the largest study of children who've been orphaned or abandoned that has been going on. We're in year 8 of data collection. And we have been following these children and watching what it is that has helped some children to succeed and for other children to not do as well, and trying to figure out what, within the context of what is already going on, what's working. So rather than starting by, we've got a great intervention here and let's see how we can adapt it somewhere else, I can't wander around too much because that, okay, which is hard for me. You know, what is it that's happening on the ground? What are people trying? What kind of homes do we have for kids? How are communities reacting? What kind of supports are neighbors giving to each other? One of the findings that we found is that most of the support for families actually isn't coming from aid organizations and NGOs. It's coming from the community itself. And so how do we bolster those? So we start with this longitudinal study, and one of the things we find is that a lot of the kids who have been orphaned and abandoned, that is just one of the traumas that they've faced, the potentially traumatic events, and that we have caregivers who are really asking for something. What can we do about their grief? Yes, we need food. We want them to be in school. We want them to be safe. But they're also experiencing this grief that we don't know what to do about. So we decided to look at traumatic grief, cognitive behavioral therapy. We did a pilot study in Moshi, Tanzania. That's now turned into a large-scale randomized controlled trial in Kenya and Tanzania. We have colleagues doing a similar work in Zambia that we're also collaborating with them. So now we have, move from what I'll call strict research into intervention and evaluation, what's working, what's not working. One of the things that we found in this first study was also that kids who've experienced trauma over time and have anxiety and depression, that their symptomatology decreases over time. So in our pilot study, we found that with cognitive behavioral therapy, symptoms decreased over time, but we don't know if that was just time, or as we talked about, having the interviewer come and talk with them. And so we really need to do these control studies, randomized control studies, have comparison groups. We're working in El Salvador, where we're looking at child care centers, so that then led us into a new world, the work we were doing. People saying, wow, these guys seem to be really good on measuring kids' outcomes and well-being, and so the government in El Salvador is trying to improve all child care centers there, and they've asked us to come in and evaluate that over time. We also ended up looking a lot at group homes, residential homes, and while we've been involved in this process, policies have been put in place in countries to try and shut down all or most of the residential homes. So we've tried to take advantage of that as a natural experiment and say, wow, what's happening to these kids? Because no one's following them out. And it's a really easy outcome. If USAID or UNICEF comes to you and says, we want you to get all these kids out of care, it's really easy to then go back to them. A few months later, you just go, you shut the doors down, kids go out, and you say, look, we succeeded. 1,000 kids, 2,000 kids, 3,000 kids out of care. What's hard is, oh my gosh, what's happening to those kids? Where are they? What processes have been in place? And for kids who do well, what were the processes that allowed them and their families to do well? So I'm trying to do some work in that area. I'm preparing, hopefully, a larger study here. In Russia, we had some work going on around HIV and AIDS. It turns out our collaborators also had access and interest in institutions. We know in Russia there have been group homes there for a long time, and the government actually puts a lot of money into those group homes. So we had a collaboration and have an ongoing collaboration that we hope will continue. I don't know if you know that things are a little hard with Russia right now, but where we're sharing findings from different places around the world and seeing what we can learn from them and what they can learn from us. That may sound odd, but if you want to know more about that, we can talk about it another time. And then we've done some evaluation work in Malawi and in Cambodia, where they had interventions with families taking care of kids who are orphaned, working through the pagoda system. So again, saying, okay, what is here? Monks have been taking care of kids for thousands of years. It's part of the Buddhist tradition that children go and live in the monasteries, even not orphans. So let's see how that's working. So these are different places where we've been working. And you notice the US is on there too. We're also looking at these issues here. And so in doing all of this, one of the things we found is that when we're looking at outcomes, again, the well-being, the psychological well-being of the kids is really important, and trying to understand how we can improve that. To talk about, so I'm going to give you just 3-4 slides on some of the results that we found. And these are results that are more thought-provoking. We have many papers and analyses out there and work that we're doing, but run a little contrary perhaps to what policymakers and what providers, we as people trying to do something for kids who are orphan abandoned on the ground, have thought. And one is, so this slide here is looking at the amount of trauma that kids have experienced who've been orphaned and abandoned, other than that orphaning and abandonment. And so we've got the majority of kids who have a prevalence in their lifetime experienced more than one trauma. And then we have the kinds of traumas they've experienced, potentially traumatic events, witnessing a family death, so actually being there as a family member was dying, physical or sexual abuse. This is life-threatening, where the child feared for their life. Violence, witnessing severe violence, where they feared for their life in the family or care setting. Being forced to leave home or care setting other than being in a residential, so actually having to kind of run. War, riots, disaster, accidents. So this is the percent. These are kids who are in group homes, kids who are in family-based care, and then we have incidents over here. So you can see even if you look at the incidents of, we'll say, physical or sexual abuse, 12 month incidents, we've got 13% of the kids experiencing those potentially traumatic events. So some of this is we really need to do a better job at protecting kids to get on the other side of the traumas, as well as doing something to help them afterwards. When we look at the number of traumatic events, now when we started this study, there were many people in the field of psychology, social work, who were saying, well, kids and adults aren't going to experience anxiety and depression in the way they experience it in the United States. So it doesn't really make sense to look at these things. I think that conversation, has moved forward for the most part. And what we found is that when we look at the number of potentially traumatic event, or the categories reported, that indeed we see, this is an anxiety scale, the PCL, that across these different categories of single orphans, double orphans, people are saying, oh, but you're a single orphan, you still got one biological parent. We're still seeing a lot of mental health symptomatology here. Abandoned kids, and importantly, over here, these are difficulty scores for non-orphan and abandoned kids living in the same area. They are also experiencing potentially traumatic events and also having mental health symptomatology. So here's the policy thing. We're always focusing on the orphan and abandoned kids, but they're living in very high-risk neighborhoods, and they may not be worse off than the kid next door. So community-level interventions are really important. But we don't see that because of the way we collect data and because of the assumptions we have when we go into the situations. Most of the kids are being cared for in the highest risk, poorest areas of different places. In low and middle income countries. Ooh, okay. That means I'm almost done. So here we've got male and female, really important near and dear to my heart because we found this in the US with people who are HIV positive, that boys, particularly pre-puberty, are as likely to be sexually abused in these very vulnerable areas here in the US. But here we have our orphan study. So you've got red is female, blue is male, and we have potentially traumatic events being endorsed. Yes, we've got higher rates on females, but the boys are right up there with us. So we have such a strong emphasis in the policy world of protecting our girls, and that's good. We need to protect our girls. We also need to protect our boys. And one could take the kind of Machiavellian of like, well, we need to protect them because they will also, as they grow up, then be at higher risk for abusing our girls. We can say we need to protect our boys. So I think this is really important, and again, something that we found here in the US with HIV positive men in a very different kind of setting. I don't know if I can get this back. I don't know what I hit. It's a trick. I sometimes do magic in my class, but not that kind. Okay, and here we've got trauma by setting, another very controversial finding that we found. There's a little unfortunate because it detracted from many of the other findings we found, is that kids in group homes are experiencing about the same level of potentially traumatic events, anxiety, depression, and other outcomes as kids living in family settings, which is the reverse also, that being in a group home is not necessarily worse than being in a family setting. So we have a whole cluster of findings that show that caring for the family as a unit is much better than caring for a child alone, in that we find that the biggest predictor of child well-being is the well-being of the caregivers, whether it's mental health, physical health, whether they've lost their jobs. Everything we look at the kid, it all depends on that caregiver. It's the largest, most significant variable that we have. So that's it. Thank you.
Let me just thank, you hear me on this? Yeah, okay. Let me thank the panel for being quite efficient on the ±8 minutes so that we'd have plenty of time to ask questions. I think when we put this group together, we knew there'd be some commonality of children and mothers and families. I had sort of forgotten how much all of your work was related yet different, so I just want to comment. That's nice. So what I'd like to do is just open it up. We want this to be interactive. There's certainly some questions I wouldn't mind asking, and the panelists may want to ask each other, but first we want to you can be specifically about studies that were discussed. You could also just ask about, a little more about getting into this field or working across disciplines. Any topic is open for questions, so please, comments or questions? Don't be shy. You're pretty shy. Yes, okay, you want the microphone? Or? Okay.
So all of your research, for the most part, seems to focus on the negative consequences that can come to light through global mental health research. And I'm curious where you guys see the field going in relationship to epidemiology and kind of psychosocial well-being, because I think we hear a lot less about the research and efforts to promote things on more subsided.
So I can say that's a great comment. And yeah, it's one of the things that as we're looking at our next phase of following the kids who are in the longitudinal cohort, is figuring out what it means to be doing well in the context of adversity in each of the settings. So we actually are hoping to go back and do qualitative work at each of the sites and say, and give examples and ask people to describe very explicitly what are the characteristics of a kid who's been in this environment doing well now. So when we ask in the abstract, everyone says, have a good job, stay in school, make money, have a good family. And that doesn't help us a lot in figuring out the outcome, which we then need to figure out how they got to that outcome. And so we're going to do things like, we hope to do things like provide our interviewers who know these kids really well now. We've got 550 kids at each site. Say, okay, tell us 20, without telling them what we're doing, 20 who are not doing well, who you think are you worried about or really doing poorly, 20 who are doing really well, and some in the middle. Select them and then have them sit down and say, okay, what are the characteristics of those kids? And then put together scenarios where they're actually able to have a little paragraphs describing a kid and say, okay, is this kid doing well or not relative to another kid? So they're really, so that's the first thing, is pulling out what is well-being, what is resilience, is some of the, or positive deviance are some of the terms that are out there, and then saying we've got this phenomenal amount of data about them that will be, 10 years at that point of data. And what are the characteristics, what's allowed them to move to this point? And this point may be being in a good arranged marriage at age 15, where that's not abusive. That may be what the community says is a good outcome here. So that's the kind of, it's really, that this is what we need to be doing more of. So that's great. Good comment.
I can just follow up on that. Let's see. Okay, there you go. So I think that the thinking going forward, just building on what Kate said, I think the positive part really comes in the context of resilience and sort of seeing, why is it the kids that we sort of expect them to have problems given the difficult environment that they're in, but they somehow break through. And so trying to understand that as a way to inform interventions and do future kind of work. But the one slightly more pessimistic thing I wanted to say is that I was at a panel with Tom Insel, who's the director of NIMH, and somebody asked him that question about, when is the NIMH going to fund something on positive psychology? And he didn't even sort of, miss a beat. He said, never, absolutely never, because we're here to figure out these diseases. So I think then the flip side of it is, global mental health will go where there's funding. And so, yes, just wanted to share that.
I would just add to that. Oh, go ahead, Lauren.
Sorry, I don't know how to figure out my mic. And I think, also thinking about early identification as a way of intervening early and improving cognitive and social-emotional development. So just adding to what Aisha said, my orientation as a clinician, I deal with disease, I deal with disorders, but I think we know that if you identify and intervene early, outcomes improve and outcomes are better, not just for the child, but for the family.
I was just going to add, to try to be a little optimistic, is you can actually still you can look for reduction in disease or pathological outcomes, but that doesn't mean you can't also include measures of resiliency. So you may still be funded for the disease state, but that doesn't mean that you can't. Part of our challenge has been getting measures that are standardized and that we can measure well. So I think that will be a great contribution of positive psychology, which is obviously a Western concept, and figuring out how we can measure that in addition to the disease states. So maybe both. Yeah, Randy.
Well, I'll just, from the fistula work, there have just been amazing applications of technology for identifying and referring fistula patients. So, cell phone technology, of course, is just, is really advancing our ability to kind of communicate and interface, but also to transfer money, for example, so that a woman, so we've gotten some small grants from the Fistula Foundation and been able to do outreach trips, and then from the KCMC office, they'll transfer money using M-Pesa, which is sort of transferring money through cell phones, that then allow the woman to buy a ticket to get into care. That's not directly related to mental health, but I do think it facilitates our ability to identify and refer people and kind of interface between the community and the clinic.
And if I can just add, so I'm affiliated with Jerry Dawson and Helen Egger and Guillermo Sapiro, and they're doing a lot of work at Duke around screening and diagnosis, sort of automating that process through using tablets and iPads. And I see that as potentially groundbreaking work because it's incredibly time-consuming, difficult. There are just so many barriers that go into accurately and reliably diagnosing this disorder in different contexts. So I see a big potential role for technology in the work that I'm doing.
Follow up on that. One of the things that we're using it for in the study in Kerala among adolescents is to try to do some direct assessments of people's emotional state. So if I can have a whole research where I never have to ask a question with the Likert scale options, that would be my dream come true. And I think technology is maybe offering that possibility, building on what Lauren said, for maybe not just diagnostic criteria, but also just trying to get understanding what's going on using imagery, using voices, things that aren't so language dependent and they're not so Likert scale dependent. So we're in the process of trying to develop those kinds of assessments. And then in the same study, sort of the other side of technology, we're interested in how technology is impacting adolescents, so around social network use and things like that. So we're both trying to use it. And
I'll say, just having come from India and talking with people, one of the things that came up in Hyderabad when they were talking about the well-being of the kids was they actually were speaking quite negatively about the use of cell phones and how it had become such a good that kids, whenever they made any kind of money, they would spend it on time for their cell phone because it was a social good and it was something. And so having Facebook and being able to having that status, but also having that tool, and they were saying it was just they couldn't see how the kids were going to be able to save money. This is it reminded me kind of some of Anthony So's work on smoking and how he used to have the studies of, families trading off money for smoking rather than food, and money for the family. So that was it, but it also leads to, one of the things they were talking about is the loneliness of kids, even in a big city, the loneliness that our kids were facing and talking about as 15, 16-year-olds, even in a community. So it allows for an intervention. So we can use the fact that they're spending all their money on time on their device.
Good questions. There was another hand in the back before, or any range of question can certainly be asked. Yes.
I think probably in your papers and research you did tackle this, but how do you take into account culture? Because, for example, in Kenya and some various African countries, you have numerous tribes, and each tribe has like their own type of upbringing, spiritual beliefs. Even in India, they have various tribes and various beliefs. So how does one go about dictating what is determined as depression, what is determined as anxiety, what is determined as anger? If you heard my mom talking on the phone back to her parents in Cameroon, you'll think that she's mad, but she's not. Like they're used to talking about because the connection is poor, or like and then I have cousins who have they've experienced multiple deaths in the family because we have large families, so that is something that they're kind of used to. But here, you may have a kid depressed because they didn't get that PSP for Christmas, etc. That's just like a plain good example. But how does one take into account the culture, which is very complex? How do you intertwine all that and confidently say, okay, kids who had this upbringing, this is what was found. So how does one tackle that?
That's excellent and complicated. You guys want to take a stab?
Yeah. Yes, really, really important that that you take into account the cultural context and experiences and how we express our feelings, and we may have the same feeling inside, but we say it in very different words. And so one of the things that members of our team have done is to go and have focus groups with different kinds of people. So you want to have women alone, you want to have a breakdown by socioeconomic status, men alone, and leaders, and ask people, what does it mean to you to have a sad child? What does that child look like? What words would you use? And sometimes people will come up with words that don't translate well back into English, like, oh, they're head holding. Well, head holding? What does head holding mean? Well, it means, like this. Okay, what is the word for that? So that's the word that's used. And then, trying to it's hard to get away from the tools that we've developed here. And in the psychology field, there's lots of, we always want the validity and reliability, and the reviewers at the NIH want to make sure you're using those tools that have been proven in the male white population. And so, we try and compare them and say, okay, we'll use some of those, but we're going to add to that and then do some comparisons. And I'm not saying that we do it as well as we should, but those are the kinds of things that we try and do that are really important.
I had an experience with the autism diagnostic tool that we were using. And it wasn't a higher module, so these children had speech. And one of the questions is you ask the child, do you feel lonely? Do other children feel lonely? What does it feel like to feel lonely? What do you do when you feel lonely? And I understand some Zulu, so I figured out that the psychologist who was administrating this assessment wasn't asking if the child felt lonely. And I asked her, why aren't you asking if the child feels lonely? And she says, because within our culture, children don't feel lonely, right? they don't. It's not something that they feel. And, trying to get it, she sort of settled on asking, do you feel bored? And obviously, bored and lonely are very different things. So I don't have a good answer for that particular question. Unfortunately, loneliness isn't part of the diagnostic algorithm, so you can sort of ignore that. Through, like Kate was saying, get the validity, go through that whole process of actually, norming these instruments in different populations. We're going to have to figure this out. So, and I do feel that children can feel lonely,
I think because that was such an excellent question, I'm just going to make one comment about that, and then maybe we'll wrap from there. Both responses were primarily about assessment, but I think it's obviously equally and sometimes more challenging to figure out what you put into an intervention that's obviously culturally tailored in a way that can have an impact in a different context. So obviously we think about both of those. So I want to thank everyone and thank all of you for coming. Those were great questions, and I know some of you may not be the open question asking type, so I was hoping to have, I've been like that before in my life. I know that's hard to believe, but so people will probably hang around for a few minutes if anybody else wants to talk to people here. All right, thank you.